welcome to the Psychiatry and Psychotherapy podcast. I'm here to talk about getting rid of burnout, increasing job satisfaction, and feeling like an expert in what you do. One thing that created a lot of burnout and angst for me was trying to get continued medical education right at the last minute. So why not join the CME membership and do CME while listening to this podcast? Go to psychiatrypodcast.com, sign up, sign in, take the test, and the certification is emailed to you in seconds. Today we'll be discussing the various psychopharmacological treatments for insomnia, some of the lifestyle and therapy recommendations as well with Dr. Cummings and two second-year psychiatry resident physicians from Atrium Health in Charlotte, North Carolina. I got connected with them from Dr. April Schindler, a former medical student and someone who I have connected with since she graduated and done some coaching with her. She's an awesome psychiatrist in Charlotte, North Carolina, if you need one. So Dr. Tomatsu is interested in the biopsychosocial connection between mental health and sleep, and Dr. Krishnan is interested in providing care for the LGBTQ community and trauma therapy. They have prepared a comprehensive 35-page handout about sleep medications, often used in practice with my mentorship, and Dr. Cummings' recommendations on articles to include. I have enjoyed their incredible work ethic, responsiveness, and professionalism. So if you know them, give them a big hug for me. There is no conflict of interests to report for any of us four doing this episode. And in this episode, we will start with an overview of insomnia, go over some treatments that we may not think about very often, such as screens before bed, and talk about it with some nuance that hopefully you learned something. I know I did. And then we discuss medications. We go over the major classes of medications, which ones are better for some situations. I had about 300 questions that came in. For those of you who are part of the free resource library, I sent out an email and got questions for this episode, and there was about 300. So we tried to include as many answers as we could. Obviously, we couldn't get to everything, so I apologize. Hopefully, you take away a lot of really good nuggets of clinical pearls that you can just immediately put into your practice. That's really the goal of this podcast, to give you things that you can translate directly into those you see. As always, I would like to thank those who continue to get CME for this podcast. I am blocking off more time to get these episodes flowing, and your support is allowing this to happen. If you don't already support this podcast, this can be done by going to psychiatrypodcast.com and signing up. I have tried to make this process super straightforward, and I think that it will be an easy way to get your CME needs met, your self-assessment needs met, while enjoying listening to this podcast. If you're listening right now, you're already listening, and so why not sign up for CME? All right, here we go with the episode. Welcome back to the podcast. I am joined with Dr. Cummings, a veteran of this podcast. I am here also with Dr. Tomatsu, Dr. Krishnan. They are psychiatry residents, second years. Dr. Tomatsu is going into sleep medicine. Dr. Krishnan, interested in trauma, helped out quite a bit, both of them creating the handout. It's about 44 pages at this point. And today we are going to be talking about commonly prescribed sleep medications. We'll talk about CBT-I just a little bit, insomnia. I asked for your questions. If you are a member of the Psychiatry and Psychotherapy podcast email list, which if you've gotten any of the resources, you are a part of that list. And I got 400 questions. So I was not expecting that many questions. It shows a lot of interest in this. We'll get to as many questions, responses as we can. But then maybe we'll have to do a Q&A follow-up to just kind of see what else we can flesh out. So Dr. Cummings and colleagues, thank you so much for joining us.
Yes, glad to be back.
Yeah, Dr. Krishnan and I are very excited to be here.
Yeah, thank you so much for being here. It's good having you guys. And this handout is pretty amazing at this point. It goes through pretty much every sleeping medication. We looked at effect sizes, side effects. So Dr. Cummings, why don't you start us off and tell us a little bit about the big picture of insomnia, and then we'll get into the medications.
Okay, insomnia is a fairly common problem. In fact, surveys in most countries, including the US, suggest that at some point, almost all individuals suffer from at least transient insomnia. The American Academy of Sleep Medicine defines transient insomnia as lasting a week or less, acute insomnia a month or less, and chronic or recurring insomnia as lasting more than a month. The other thing that's interesting about the broad population statistics is that primary sleep disorders are relatively rare compared to secondary sleep disorders. Some 90% of sleep disorders appear to be caused either by other psychiatric disorders such as depression or anxiety or psychosis, or by associated comorbid medical illnesses. About 5% are primary chronobiologic disorders, and about 5% are primary insomnias of various types.
Yeah, I can relate to that. I recently had COVID and probably the worst insomnia I've ever had. and the sort of the fear of the future, what's going to happen also kind of made that worse.
Mm-hmm.
We were talking about COVID before we came on here, and I don't know. Have you seen that with COVID at all, Dr. Cummings? Or
Quite a bit. There's both insomnia as a common component during the actual acute phase of COVID-19 infection, and there also have been several studies looking at either what's come to be called long haul COVID, those people who were unfortunate enough to have ongoing symptoms for 3 months or more. Insomnia is a common component of that. And then even in people who don't have long-term COVID symptoms per se, post-infection anxiety, cognitive deficits, and sleep disturbance are very common, at least for 6 months following the infection.
Yeah, I've had a number of cases like that. Okay, so getting back to this overview, what would you consider terminal insomnia? Some people ask some questions about terminal insomnia.
Okay, in terms of the structure of insomnia, sleep scientists have largely described it in 3 phases. People can have initial insomnia, which essentially is difficulty going to sleep. Middle insomnia, which is characterized by waking up during the middle of the night, in particular around the time of the inflection point for low body temperature and what should be maximum melatonin plasma concentration. And then terminal insomnia is early awakening, in essence. That is waking up early in the morning before the person should be waking up.
So when you think about just general treatment, and you're taking your history of insomnia, are you trying to delineate like when this happened, what started it, what coincided with it, what time of the evening it is? Like, what are some of the general?
Yes, and indeed, I think one of the core elements when somebody presents with a complaint of insomnia, as in all of medicine, the first step is not to reach for the prescription pad. The first step is to ask them about the insomnia. Indeed, when did it start? Were there associated factors, illness, injury, acute stressors, change in job demands, change in habits around bedtime? Do they wake up early, middle, late? Are they awake all night? Because essentially what the clinician should be attempting to do is discover if there are identifiable causes of the insomnia, because indeed the treatment needs, of course, to follow the cause. If, for example, the person's insomnia is caused by a pain disorder, then treatment of the pain may be the focus of treatment. If it's being caused by a central or obstructive apnea, that needs attention. If it's being caused by a comorbid psychiatric disorder, often treatment of the comorbid disorder rather than the insomnia itself becomes the focus of treatment. which is a roundabout way of saying that we, as in all things in medicine, we need to look for what's causing the insomnia before leaping forward to choosing a treatment.
Yeah, and Dr. Tomatsu and Dr. Krishnan, you can jump in whenever you want if you have any questions for him as well.
Yeah, I definitely agree with Dr. Cummings. With medication, it could physically knock you out and put you to sleep, sure, but it may not enhance the quality of sleep, and it's masking the underlying cause of insomnia. And CBT-I is really the gold standard recommendation from American Academy of Sleep Medicine. But why is it that we don't do a lot of CBT-I? It primarily has to do with the fact that, it's a time-intensive therapy course. And, if someone cannot afford it, insurance. So all those barriers are there, which causes patients to not prefer CBT-I as the first line of treatment. And that kind of puts us in a position where, if the patient is saying, I want to sleep tonight, we look at the medications that could potentially help them fall asleep, but we're not really treating the insomnia.
Yeah. And indeed, sometimes there are some very simple environmental interventions. I have seen patients, for example, where when you ask them about their sleep, you begin to discover things such as they're drinking a stimulant just before bedtime, tea or coffee. They may be engaging in activities such as late night reading on a brightly lit screen, which is a great way to cause circadian disturbance, or engaging in vigorous exercise just before bedtime, another way to wake yourself up. Or they follow an erratic sleep pattern because they're doing shift work or other such things. Many things in the environment can also cause difficulty with insomnia.
Yeah, we had some questions about adolescent sleep, and one of the studies that I found showed that a lot of adolescents are on their phones in the middle of the night. And I've done all of those things that you listed, by the way, Dr. Cummings. I think I had coffee last night, which was like a bad decision.
And unfortunately, especially with, now that we live so much of our lives on screens, unfortunately, the screens we're using often emit light in the part of the spectrum that human beings are most sensitive to in terms of resetting the suprachiasmatic nucleus, the internal clock. Humans are relatively insensitive to light at the red end of the spectrum above 680 nanometers. As you get down closer to the blue-green end of the spectrum, our sensitivity peaks at right around 210 nanometers. And unfortunately, a lot of our phones and computer screens emit a lot of light toward the blue-green end of the spectrum. And that's a great way to suppress melatonin and essentially make your brain think that, oh, it's morning, I need to wake up.
What time do you recommend? Like, some people wear like these glasses that stop the blue light coming through, or you can have your iPhone or phone often stop showing these colors.
Yes.
What time of day do you recommend? How many hours before sleep? Like, let's say someone's going to sleep at 10 o'clock. What do you recommend?
They should stop probably exposure to light by around 8 p.m.
And this isn't like light as in like lights on the ceiling, is it? Or is
No. In fact, it wasn't until 1980 and a researcher at the University of Oregon, Al Louie, discovered that human beings actually were sensitive to light. Prior to that, it was thought that humans didn't respond in terms of their chronobiology to light exposure. Because compared to nocturnal animals, we're way less sensitive. But he demonstrated that if you get the light bright enough, we do respond. For white light, a human being requires exposure to about 2,000 lux, which is about what you'd get if you were standing close to a window on a sunny day. In contrast to that, most of the lights in people's homes, bedside lamps, ceiling lamps, the average lighting is right around 500 lux, which is below the level that human beings will respond to.
Okay, but there's something about the screen being up close to your face and the brightness of it.
Yes, it's close, it's bright, and unfortunately, these settings tend to be toward the blue end of the spectrum, which we're more sensitive to.
Okay.
I had a question, Dr. Cumming. So I looked into the blue light walking glasses a couple of years
Mm-hmm.
ago, and at least at that time, I couldn't find any actual evidence of those glasses being helpful because they're not harmful. It's one of those, well, if you think it helps you, great. But there really was no concrete evidence as to those pair of glasses helping.
Indeed, there is not great data to support the glasses. In part, I think because people still tend to expose themselves to more light than they should when they're using glasses that block part of the blue-green spectrum. The other issue has been that there's been a huge amount of variability in the quality of the glasses that people buy. I think probably the better advice for our patients is to stop looking at screens that emit bright light at least by 8 o'clock in the evening. The onset for most people with a fairly average sleep-wake cycle for onset of melatonin secretion is right around 9 p.m. So if you're exposing yourself to bright light at 9 p.m., 10 p.m., 11 p.m., you're going to be causing a suppression of melatonin secretion, and the consequence will be that you will phase delay your sleep-wake cycle because your brain doesn't yet know that it's dusk, that it should be time to go to bed. Essentially, melatonin is the neurohormonal reflection of dusk, or sundown. The sun's gone down, it's getting dark.
Yeah, I could improve my own my own patterns here. One thing that I've realized is like sleep associations. As I'm thinking about this, I'm thinking probably most people who are listening to this have a sleep association of being on their phone before bed or having the TV on, or a lot of people have that, at least that I talk to. And so the sleep association may take a couple days to break, because we're so used to that which we sleep around.
Yes.
So like I've had a couple clients who like TV is their sleep association. So I said either you have to have the TV on all night or you have to completely remove the TV, because when you wake up in those lighter cycles of sleep, you want that sleep association, and that's why you're waking up, every 2 to 3 hours throughout the night. I don't know if you have any thoughts on that.
I would certainly encourage people to migrate away from things that emit light at night and move more toward, if they need a sleep association, pick something relaxing like background white noise. There are plenty of options such as babbling brook sounds, rain, other sounds that people may find soothing and may actually help keep them awake, or asleep rather. So certainly a place that all of us, I think, can improve our sleep is by improving sleep hygiene. One of the mantras during the sleep research that I did was that people should not, take work projects and other things to bed with them. They should use the bed for sleep, essentially, rather than all sorts of other things.
Sleep and sex.
Yes.
No arguments in bed is one thing that I say to clients as well.
Yes.
Don't argue in the bedroom, because then that will be associated with like sleep, right? Or sleep will, it's kind of like,
Yes.
yeah.
Yes.
I had a patient that was pretty interesting. So she would have like Western cowboy movies playing before she would go to bed. And obviously the first thing we thought of was, well, let's turn off that TV in the bedroom. But when we really got to the bottom of why she was watching specifically Western cowboy movies before bed, it turns out that when she was little, she used to crawl into her parents' bed and they would always watch cowboy movies before bedtime, and it would soothe her to fall asleep. And so when we heard this, we realized that for this patient in particular, even though, TV is not really recommended for most people before bedtime, for her, it was actually acting as a way to calm her brain down and calm herself down at the end of the day to fall asleep. So I just thought that was really interesting that,
Yeah.
even the majority, TV is bad.
People can do something like that. I do make a couple of suggestions in those cases. One, they should set a timer on the TV so that the TV will turn itself off after they go to sleep. Because there's nothing like going to sleep with a soothing Western and then waking up at 1 a.m. when the infomercial comes on. And the other thing they can do is be sure that the TV screen is not overwhelmingly bright. Most TVs have some capacity, either by placing it further away or by angling it, or in some cases, depending on the TV type, you can actually change the brightness of the screen so that it's dimmer. So if it's dimmer and it's soothing and then it turns itself off after you go to sleep, that's not so bad. What you really don't want is something bright and glaring that might initially be soothing, but then at 1 o'clock in the morning, the guy who's trying to sell, Ginzu knives or whatever comes on and is yelling at you.
Yeah. Oh man. Wow. Well, I mean, there's so much here like that's behavioral. And one thing you mentioned, Dr. Cummings, is don't exercise before bed. I used to exercise at 8 o'clock every night just because that's when the kids were sleeping and I could exercise. And then like once I started deadlifting heavy, I noticed it was hard to sleep. So, but I do think that exercise in general does help with sleep as well. And that's one of the recommendations I make.
Yes, exercise is very helpful with sleep, especially aerobic exercise, but it shouldn't occur just before bedtime, because if you're exercising, you're intentionally increasing sympathetic activity and tone,
Yep.
and that will keep you awake.
I have a question for you, Dr. Cummings and Dr. Pewter, about how to improve sleep overall in the inpatient setting. I know we have a lot of non-pharmaceutical options kind of on a day-to-day basis that we can manage with patients on an outpatient setting, but acutely, we use a lot of pharmaceutical options, but what can we do otherwise to just stay away from using the drugs?
There are things in hospitals, by the way, in general, are terrible places to sleep.
Terrible.
In part because, in many hospital settings, especially medical wards, the nurse is going to come wake you up in the middle of the night to take vitals, etc. In cases where people don't really need their vitals taken that often, one thing physicians can do is actually do away with the nocturnal measurement of things like vitals. If somebody's not being treated for something that involves disturbance of their vital signs, that particular medical habit is not something we actually have to do. We can also be sure that medications are scheduled so that if the person is somebody who goes to bed earlier in the evening, we don't necessarily want to wake them up after they go to sleep and say, here, I have a medication for you to take, that sort of thing. So doing those sorts of things in the environment, and certainly working with the hospital administration and nursing staff, hospital units can be looked at in terms of changing the lighting in the evening, changing the noise level. Now, there's some areas in hospitals where that's very difficult to do. ICUs, for example, often actually induce delirium because of all of the alarms and machinery and the activity. The person is in an environment that doesn't have good time cues and which is, in many cases, determined to keep them awake 24/7.
Those are all good things. I would say, there are situations where meds are going to be very important. I think especially about like bipolar patients. I can't imagine treating them without sleeping medications almost. I don't know, Dr. Cummings, if you have...
Yeah, there are situations in which sleep medications are useful. We should always, when we can, be attempting to use them for as short a period as feasible. In part, that's because there are a number of studies that have shown that chronically taking sedatives or anxiolytics is associated with an increased mortality rate, usually with a hazard ratio of between 3 and 4. So these are not inherently innocuous medications.
Are we talking about benzodiazepines or?
Benzodiazepines or the selective Z drugs. Both have been associated with increased mortality rates when taken chronically.
Now, is that because these people are sicker and these people have lots of other problems and that's why they get on these drugs? Or is that because, the drug itself and the risks that the drug puts them at?
It may likely be because of the drug itself. One of the studies I included or that I sent to you for inclusion along with the information to go with this podcast was a very large United Kingdom study in which they looked at literally thousands of patients in primary care and found an association with a hazard ratio above 3 for treatment with anxiolytics or sedatives. The people who were being treated with the anxiolytics and sedatives were compared in a 2-to-1 ratio with people who were not taking sedatives and anxiolytics, but they were all being treated in a primary care setting, which would suggest they were all suffering with a variety of medical problems. The rate of mortality, all-cause mortality, was higher in the people who were taking sedatives or anxiolytics for a long period of time. They specifically did avoid looking at people who were severely ill, terminally ill, so that one of the things included in their model is people had to survive for at least 12 months after entry into the study in order for their data to be included. So these were not people who were receiving massive amounts of sedatives or anxiolytics because they were at the end of life.
Yeah, Dr. Cummings, I took a look at that study. I found it to be really interesting. I mean, they were able to kind of control for a range of psychiatric and physical comorbidities and match, so that they could get as close of an approximation as possible with, the impact of benzodiazepines and the Z drugs.
Yes.
And that, and absolutely like a 3 to 4, 3 times to 4 times more with the Z drugs and the benzodiazepines compared to people of similar backgrounds. And so.
Well, indeed, that was one of the things that prompted them to pursue this very large scale study was that smaller, shorter studies had frankly produced mixed data, in part because of the problem of comparing oranges and apples, people who had different types of illness that were on drugs for varying lengths of time. So they didn't have good direct comparison. So this study was unique and was very beneficial in terms of helping to isolate those people taking sedatives and anxiolytics versus those people who were not.
So there's data in the U.S. that like 12.6% of adults reported past year benzodiazepine use, and misuse accounted for nearly 20% of overall use, highest in the range of 18 to 25 and lowest in the elderly, which is 0.6%. So mostly the elderly are not misusing these drugs, but it's just like 1 in 10 people is on one of these meds.
So, and if you look at that data from that was taken, I think, from the National Survey on Drug Use and Health in 2015 and 2016, misuse was the highest in the younger population, but in terms of use as prescribed, the highest number of prescriptions was actually in adults over 50 years old.
Yes, which brings us back in some ways to where we started with. We should be looking for underlying causes of insomnia rather than committing the individual to chronic insomnia treatment. And although the other thing about the benzodiazepines that as a pharmacologist I always bring up is that for treatment of insomnia, the benzodiazepines are useful as very short-term medications. Somebody who has transient or acute insomnia, but people become very tolerant of the benzodiazepines in terms of sedation very quickly. By the time somebody has taken a fixed dose of benzodiazepine for 4 to 6 weeks every night, it no longer has a sedative effect. When I was at UC San Diego, we did that study in which we looked at people, put them on a fixed dose of temazepam, and indeed their sleep duration, their sleep efficiency improved during the first week of treatment. Then it began to deteriorate, and by the time they were out 4 to 5 weeks, their polysomnogram looked just like it did the first 2 nights when they were only taking placebo.
Yeah, there was a study we found on CBT-I versus temazepam in 2006. It was a randomized controlled trial, and what we found was that after 3 to 8 months of follow-up, it seemed like the CBT-I was considerably better. Do you want to speak to this study in particular? Who looked at this one?
Yeah, that was me, Dr. Krishnan. So it was a 2006 randomized control trial. It compared CBT-I with a combination of CBT-I and temazepam, and then temazepam alone, as well as a placebo. And they looked at outcomes of sleep latency, efficacy, and total sleep time. And initially, kind of within the 8 weeks of the treatment duration, the temazepam alone group actually did better than the CBT-I, but in terms of the sustained, improvements at 3 months and 8 months, that was really only observed with the CBT-I group.
Mm-hmm. Yeah. As a provider, what I got through the emails was a lot of people are frustrated on how difficult it is to get patients into CBT-I. So one of the episodes I want to do in the future is just like teaching CBT-I to the providers, giving them a handout where they can get started doing that on their own. But I'm wondering, Dr. Cummings, with this knowledge that CBT-I is so effective and it's so difficult to get patients this treatment, what do we do as providers? When we get hit with someone with insomnia and we want to help them.
Well, I think indeed short-term use of sedatives, particularly the Z drugs, can be useful. They do not disturb sleep architecture nearly as much as the benzodiazepines or the antihistamines do. So they can be useful, particularly in people whose insomnia is not chronic. And indeed, the vast majority of people who have a difficulty with insomnia have it for a shorter period of time. They either have transient insomnia or acute insomnia, but not chronic primary insomnia, although there are such people. The Z drugs, at least zopiclone outside the U.S. and S-zopiclone inside the U.S., has been used to treat chronic insomnia successfully, albeit it comes with that risk of an increased hazard ratio for all-cause mortality. I think the other thing that we can do, the other primary type of insomnia, the circadian disturbances, we do have good interventions for that. If people can find a reliable source of melatonin, that is useful as a chronic treatment, does not appear to have much of a downside for circadian disturbances. And we also have Ramelteon and Melatonin, which are synthetic analogs of melatonin, which can be used to treat people with phase disturbance or shift work or jet lag types of insomnia successfully without a lot of downside or risk.
Okay, so a couple things people asked about. One is, can you take melatonin long term? What dose is the best? What dose is the best for children specifically? Is 20 milligrams too much?
Most of the studies which have looked at modulation of circadian rhythms have found that the peak efficacy occurs between 3 and 5 milligrams a day, usually taken in the early evening, about an hour before the natural synthesis and release of melatonin would begin. So we're talking about taking the melatonin dose around 8 in the evening for most individuals, or about an hour before they would like to start to become sleepy. Now, if you raise the dose, at least the studies I've looked at haven't found anything catastrophic that occurs. At doses above 5 milligrams, the melatonin begins to become directly sedative. And by the time you're up to around 15 to 20 milligrams, people then do have some impairment of alertness and cognition, at least in the early part of the following day. So my guess is for most people, you're probably looking at a dose range between 3 and 5 milligrams. As in most things, melatonin has not been as well studied in children as in adults, although there is no evidence of toxicity in children.
I have a question. I read somewhere that the melatonin receptors in our brain are saturated at 1 milligram or less of oral melatonin.
Yes.
And so I guess my question is, everything you see over the counter really starts at 3 milligrams plus.
That's largely because when you're taking the medication exogenously, melatonin and the two synthetic analogs all have fairly limited bioavailability when ingested. The other issue with melatonin is that melatonin, Ramelteon, and Tassamelteon also are very short half-life drugs, which of course is different than melatonin being supplied by the pineal gland because it's engaging in synthesis, particularly during slow wave sleep throughout the night, so that it doesn't go away quickly. Whereas the pill the person takes, if they were to take 1 milligram, their melatonin receptors would be saturated, but it would be a very brief saturation because it falls off so rapidly. Half-life ranges from a little less than an hour to about an hour and a half. So
I see.
The oral medication goes away quickly, unlike what occurs in the pineal gland, where synthesis begins once darkness occurs and then continues throughout the night, beginning to fall about 2 or 3 in the morning and then being truncated by sunrise the next day.
So the other thing I wanted to ask you was about Ramelteon. Oftentimes, a lot of insurance don't cover Ramelteon for the patients, at least I've encountered. And so I definitely don't have a lot of experience with it. But when I looked into the literature, it looks like there was a study that showed if you take Ramelteon compared to placebo, people may fall asleep about 19 minutes faster if you take 16 milligrams of Ramelteon. But in the big picture of things, is that really clinically significant?
For most people, no. The dose range for Ramelteon is 8 to 16 milligrams. Its bioavailability is 1.6%, so truly awful bioavailability. It does improve sleep onset and very early stage sleep. So if that's the person's problem, it works very well. If they're having more difficulty with middle and terminal insomnia, frankly, taking an oral dose of Ramelteon is not going to do much for them as a direct sedative. The other area where Ramelteon or Tassamelteon or melatonin actually is better than being a direct sedative is when the person has issues with, for example, phase advance of their sleep-wake cycle. A good example of that are in older people, elderly people who want to go to bed at 6 p.m. and then get up at 2 in the morning, and they're not very happy because that doesn't fit, their social obligations very well. If they take even a modest dose of one of these chronobiology drugs in the early evening and they can retrain their clock so that it phase delays, they can start going to sleep more at 10 and getting up at 6. Now, if you reverse that and you take one of these drugs in the early morning, say you set your clock and you take a dose at 5 or 6 in the morning, you'll actually cause your brain to think that it's staying darker longer, so you'll phase delay your sleep. In the middle of the day or in the middle of the night, the response to melatonin or the analogs is fairly negligible.
Okay. So you're saying in general, good for sleep onset issues.
Good for regulating your clock, but not so good as a direct overall sedative.
Okay. I want to jump back to benzos real quick because there was a question in a previous episode on if it increased the risk of dementia. And when I asked you about this, Dr. Cummings, we looked at a paper, and you said that was never really a big concern for you. And that was
Yes.
actually really helpful. The concerns are for short-term memory issues, working memory, processing speed. Are those issues, because they're taking this at night before bed, are all of the benzos affecting people during the day? I guess would be one of my questions. And any comment you have on the dementia risk?
Taking benzodiazepines chronically is statistically associated with an increased rate of dementia. It's not clear that the benzodiazepine is causing the dementia. It may well be that people who suffer from chronic anxiety, insomnia, and other issues for which they're taking the benzodiazepine, because their association, those people also have a greater burden of general physical illness and so forth. All of those things can be risk factors for dementia. The degree of impairment caused acutely by the benzodiazepines during the daytime depends on the half-life of the benzodiazepine. For example, if the person is taking a long half-life benzodiazepine like clonazepam or diazepam, yes, it's clearly present at bioactive concentrations throughout the day. If they're taking a very short half-life benzodiazepine at night, it may be having minimal effects during the daytime because it's largely washed out. But then again, you have the issue that the benzodiazepines rapidly become ineffective as a sedative. So, my own view, as I've expressed before, is that benzodiazepines are good short-term rescue medications, either for sleep or for anxiety. They are generally dangerous long-term medications because of the increased mortality risk and increased cognitive impairment they cause.
So I do have, I want to comment on that as well. So there was a 2020 study that we found that was done in Denmark, which they looked at the prescription registry data for benzodiazepines and Z drugs in patients with affective disorders. And it was a large study. They did it from 1969 to 2016, looking at the data, and they looked for a diagnosis of dementia or prescriptions for dementia during 6-year follow-up periods. They didn't really find any association between use of benzodiazepines or Z drugs with the diagnosis of dementia. And I wanted to hear your take on this possible protective effect. The study concluded that, continued and new users of benzodiazepines had lower rates of dementia compared to those with no lifetime use or patients with former use. And one of the hypotheses was that the calming effect of benzodiazepines kind of reduced the pathological effects of stress on the brain. So I would like to hear your take on that as well.
It's an interesting hypothesis. It seems to run counter to other data that's out there in terms of long-term risks of benzodiazepines. Even if it were true that it decreases the risk of dementia, the increased rates of depression, increased mortality risks, I think might be offsetting effects.
Okay, I think we've demonstrated that ideally someone who's elderly would not be on chronic benzodiazepines for sleep. If we get inherent, if we, end up with a client who's on a benzodiazepine and sleeping well, and we want to taper them off, and the patient's willing to be tapered off, how fast do you do that?
Very gradually. One of the chief problems that physicians who practice in this area have is they underappreciate that if a person has been taking a benzodiazepine for a long, long time, that taper needs to be incredibly slow. We're talking about, for a therapeutic amount of sedative, taking as long as 6 months to a year to taper the person off of the medication. Because going faster will very likely cause the person to have a relapse of insomnia or anxiety. And if it's very fast, may actually cause withdrawal signs and symptoms. So it's prudent to go very slowly in terms of tapering a benzodiazepine. And frankly, you may find in some people that there is underlying pathology that will prevent you from taking the person all the way off. For example, I had a patient who, years before it had catatonia in association with depression, came in with 2 milligrams every night of clonazepam, was able to get that patient down to 1/4 milligram of clonazepam at night. Anything below that, and the person began to become catatonic.
Yep. Yep.
So they stayed on 1/4 milligram.
Yep. I think that's actually worth reiterating. Something we talked about in our catatonia episode is it's so important to go down super slow. Like we're talking about, let's say if they get discharged to you as their outpatient provider and they're on 20 milligrams of Ativan, going down 1 milligram a month would be appropriate, and then watching for signs of relapse into catatonia.
Yes.
I had one of these patients as well, drop them down to 2, from 2 to 1.5. That's when they develop the catatonia again. So I don't think that that's common practice. So I think that's good to talk about again and again.
Yeah. Physicians sometimes tend to be too much in a hurry.
Yeah.
The brain in general, no matter what we're talking about, is far more tolerant of gradual change.
Yeah. In my IOP, it's common for me to make a med change and then wait for a month or 6 weeks. And in the meantime, once a week, I'm talking to them about exercise, diet, lifestyle, sleep hygiene. I'm using that time for other things, and I'm monitoring side effects and stuff. So important. So, okay. Decreased taper, very slow, 6 months to 12 months. Very good. Yeah. Any other comments on benzodiazepines? In the handout, we have individual ones listed, effect sizes, unique risk factors, but I want to get kind of an overview from you.
I think, again, if I'm the person who's deciding whether to use a benzodiazepine or not, I'm looking for short-term use, essentially as a rescue medication, recognizing that there may be clinical circumstances where the person will need to take it chronically, but I try to avoid those whenever I can. In some ways, I think of the benzodiazepines as being similar to the high-potency steroids. Excellent for rescue miserable long-term medications. And the same thing with sedative medications in general. In this case, the direct sedatives, the Z drugs, the orexin antagonists. I'm looking for short-term use, not long-term use, although the orexin medications appear to be safer long-term than the Z drugs, provided they don't cause narcoleptic symptoms. There are now 2 of them. You have suvorexant and limvorexant. They're very similar to each other. They're both orexin 1 and orexin 2 antagonists. The limvorexant is a little more potent with a dose range of 5 to 10, whereas the suvorexant's 10 to 20. So those are useful. By and large, for sedatives, true sedatives, about all I order are the Z drugs and the orexin antagonists. In psychiatry, it's also very common to use a variety of things for sedation. You'll see people use Trazodone, low-dose Quetiapine, diphenhydramine. In all of those, essentially what you're giving the person is an antihistamine as a sedative. My own favorite, if I'm going to use an antihistamine, is hydroxyzine, because it is not anticholinergic, so it doesn't disturb REM sleep. and it doesn't come with other effects other than histamine blockade.
I think what do you think about doxepin? Because I think that's at low doses highly histaminergic, and it seems
I agree.
to, I'm talking about like
Doxepin is
5,
my
10
go-to.
milligrams.
Yeah, can be. Yeah, doxepin in very low doses can be useful. It was remarketed at 6 milligrams as a sedative. Frankly, there's no reason to pay the extra money. Giving the generic at 5 to 10 milligrams is essentially biologically equivalent. And again, though, what you're really giving the person is an antihistamine.
Yeah. I was a little bit disappointed by the Trazodone data that I saw. It didn't seem like it was that much more effective for sleep, yet often I hear from patients it's helpful for sleep. Any thoughts on that?
So I actually looked into Trazodone, and the history was so fascinating. It turns out that there's this concern of tolerance and dependency with benzodiazepine. And so physicians decided, hey, let's prescribe these antidepressants off-label, especially Trazodone. And so when they looked at these office-based surveys from practices between 1987 to 1996, there was a 50% decline in benzo prescriptions that coincided with 150% increase in Trazodone prescriptions. And then, like you said, Dr. Peter, the data that I found, it really showed that Trazodone may help someone fall asleep 10 minutes earlier than placebo, which again, is that clinically significant? And if someone were to wake up in the middle of the night, they were able to go back to sleep 7 minutes quicker than placebo. So that's not really strong evidence that Trazodone is really helping. But Dr. Cummings, what do you think?
I haven't found Trazodone to be all that useful. The other concern I have with it is that people tend to forget that Trazodone is an antidepressant. And I've seen people make the mistake of giving somebody who is bipolar and hypomanic or manic Trazodone as a sedative, thereby helping to drive their hypomania or mania.
Yeah. I see that often, and like they'll crank it up to 300, not realizing like, hey, this person is not doing well because of that high dose of the Trazodone. The biggest issue that I see with it, outpatient, Dr. Cummings, is sedation during the day. It seems to have this second dip. It has like the initial dip that gets them to sleep. They'll wake up at 2 to 3 in the morning, and then they'll have this second dip that hits them right at 6 a.m. It's so miserable.
Yeah. And it's a case of, well, if I'm going to choose an antihistamine, the reason for my preference for hydroxyzine is that it lacks all of the undesirable side effects. Quetiapine is an alpha antagonist fairly robustly. So is Trazodone. Diphenhydramine is very highly anticholinergic. Hydroxyzine is not anticholinergic. It has no affinity for alpha receptors. So if you want to give somebody an antihistamine, why give them something that will do all sorts of things that you're not looking for?
Okay. And what about dose for hydroxyzine? What do you look at?
Usually 25 to 50 milligrams at bedtime. Now, the other caveat with using an antihistamine as a sedative is the site of action for an antihistamine is primarily cortical, particularly prefrontal cortical. So you do an effective job of turning the cortex off, but you're not having much of an effect on the subcortical systems. So in a few people, particularly the elderly and children, you may get idiosyncratic activation because essentially you've turned off the person's cortex, but not the rest of the brain, and and behaviorally they may run amok on you.
Yeah. What do you think about Mirtazapine? I know that's commonly used. It's been effective for some of my patients where Trazodone hasn't been effective, where doxepin hasn't been effective.
Mirtazapine also is acting primarily as an antihistamine at low doses. This is a drug that as you increase the dose becomes less sedating because its effect at the alpha-2 receptor causes an increase in norepinephrine release as the dose goes up, so that by the time people are taking more than 30 milligrams a day, the drug is not very sedating at all, whereas at 7.5 to 15 milligrams, it's pretty sedating because the antihistamine effect is present long before the increase in norepinephrine secretion.
One thing that I read with mirtazapine is one of the major side effects is the discontinuation syndromes and having this almost withdrawal-like experience. But does that
Yes.
happen with low dose?
It is less likely with low dose, as you'd expect. However, it is not zero. If the person has been on mirtazapine for a long time, I generally recommend that people taper the drug rather than stop it abruptly. Basically explaining to the patient that there is a risk of a withdrawal syndrome should they go from a dose that's effective for treatment of akathisia or depression to nothing. Whereas they can go from, whatever dose they're on gradually down to 7.5 and then stop at that point.
What do you think about magnesium? I got a couple people, one that said that it worked for them, a couple people asking about if there was evidence behind it. Any thoughts on that?
Magnesium does decrease brain excitability largely by blocking calcium influx at both AMPA and NMDA receptors. So there is a possible theoretical mechanism for it causing calming. It is not reported by most people to be directly sedating. And I haven't, frankly, seen any good, well-controlled studies where it was compared to placebo, specifically in groups that were suffering from primary insomnia.
That's really interesting because when I looked into L-theanine, it was something very similar where the thought process is that, there's an action on this AMPA and NMDA receptor, and it blocks the reuptake of glutamine and glutamate. But in terms of efficacy, I think there's only one rat model that I could find where they showed maybe some effect on sleep onset latency.
Mm-hmm. Yeah, so I think the data on magnesium is basically at this point still out.
I think with like L-theanine, part of the problem is we don't have big studies being done on this because there's no money behind it.
Yes, and the same thing would be true of magnesium. There is no pharmaceutical firm who is going to be investing large amounts of money in studying the effects of magnesium on sleep.
Yep. Interestingly, if you look at some of the sleeping medications over the counter, a lot of them will have L-theanine in the combination of the sleeping meds. It'll be like a cocktail of stuff. Any other comment, Dr. Cummings, on over-the-counter sleeping medication?
Most of the over-the-counter sleeping medications are indeed mixtures, with at least one component typically being a drug that has antihistaminic properties. I do think people need to be careful in that those, when they choose an antihistamine, they often choose the cheapest they can get, which by and large is diphenhydramine, Benadryl. And the problem with Benadryl is not that it's a bad antihistamine. It was the very first one developed. It's that it's also highly anticholinergic, which can cause all of the anticholinergic side effects that people deal with, including memory impairment, blurred vision, dry mouth, constipation, urinary retention. So people can run into all sorts of difficulties because of that component of the drug.
Dr. Cummings, what are your thoughts on valerian? When I looked into it, the mechanism of action was very vague, and all I could find was that it binds to the GABA A receptor and, quote, allosterically modulates the receptor. Have you found it to be helpful?
It is a sedative, both in purified form and as the nutritional product valerian root. Of course, as with most nutraceuticals, frankly, the control over manufacturing quality is not very tight, and consequently the quality of products that are out there is highly variable. Valerian is sedating. It's been used for traditional cultures for literally millennia as a sedative. We use a modern variant of it as a mood stabilizer. Valproic acid is a derivative of valeric acid and has in some ways, some similar effects. I frankly wouldn't prescribe it. I don't typically recommend nutraceuticals very often because of the poor control and lack of good testing and study.
We haven't talked about a commonly used one, Seroquel, which is often used inpatient from what I've seen for sleep. I think they're using it for the antihistamine effect, but
yes,
I think it's worrisome because of some of the side effects. Do you have any thoughts on this, Dr. Cummings?
Yeah, I tend not to suggest Seroquel, Quetiapine as a sedative. It has, of course, it's an antipsychotic, albeit it's a fairly weak antipsychotic. Its dissociation from dopamine receptors limits its effectiveness as an antipsychotic medication. It's also a very potent antihistamine, which provides the sedative effect. It's also a very potent alpha adrenergic antagonist, which can cause difficulties with, problems people can have in terms of hypotension, etc. But, I think psychiatrists reached for it just because it has antihistaminic properties. I'm a little uncomfortable with using drugs off-label that haven't been well studied and which do things other than what I'm looking for.
Yeah, that's good. Okay, so one of the common questions was any advice for people with sleep apnea who are not responding to a CPAP or who have difficulty with the sleep apnea machine?
Yeah, a lot of people have difficulty tolerating CPAP. Many of the machines are noisy. There are a variety of machines produced, so they can try to look for a better machine. There are also surgical revisions of the palate that can be considered and may be effective in some individuals. Probably the principal thing, albeit it is not easily accomplished, is weight loss will in many people cure their apnea.
Yeah. Yeah.
So one of the studies, I think Dr. Cummings, you had emailed to us, was on obstructive sleep apnea and
Yes.
drugs. So I read through that study. It was really interesting because they looked at the the respiratory arousal threshold. And the idea is that people with obstructive sleep apnea have low levels of respiratory effort, which leads to frequent awakening and a greater ease of arousal. And so they looked to see if isopicolone and zolpidem, which are two Z drugs, specifically have any impact at all in sort of raising this level to impact and help with sleep, but they actually didn't really find any evidence. So I was wondering if you could comment on that.
Yeah, the Z drugs have not been found to be very useful in apnea. And of course, the benzodiazepines are overtly dangerous in sleep apnea because they may indeed make the person not respond to rising CO2 levels. And consequently, they may artificially produce a combination of obstructive and central apnea, which can be fatal, of course, for the person. I think it's important for the listeners to understand the reason people are so tired when they have obstructive sleep apnea is that they spend most of their night waking up several times an hour in order to breathe. When they are asleep, they often stop breathing for periods of time. Their CO2 level begins to climb, and eventually it causes them to gasp, snore, strangle, and essentially they're having to wake up over and over and over again. And of course, that's exhausting. That's not exactly conducive to a restful night's sleep. The point of the CPAP machines is to maintain positive airway pressure so that the person's airway doesn't obstruct, doesn't close down when they go to sleep and the muscles relax. Unfortunately, those machines are not entirely comfortable, and in some cases, depending on manufacturer, they're also somewhat noisy.
I've had, we should do a full dive on this. I've had so many patients who have such issues, so much resistance using these machines, that it's something I often will ask patients. I'll often get studies, sleep studies. That sometimes takes a lot of convincing as well. And then when they have an issue with them, I'll sometimes have them bring in the mask, and we'll do some relaxation stuff with them, having the mask on with me in the room. And that can sometimes help. Any other like tips or tricks that you have, Dr. Cummings, on how to get people to do the study, to wear their CPAP 100%, right? Because often as well, you should be asking if the patient has sleep apnea, what percentage do you use? You know, most patients don't use it all the time. They'll be like, oh yeah, I only use it like about half the time. Or, oh, it comes off in the middle of the night and I don't know how, you know? So any other thoughts, pearls that you could give?
It's important to indeed do the kind of analysis where you have the person bring in the mask and one, be sure it fits them and is comfortable. People can, of course, if the machine is keeping them awake because of noise, earplugs can help. Basically, the person who is using a CPAP machine needs to be sure that their sleeping arrangements are otherwise as comfortable as they can make them. Because unfortunately, introducing a CPAP machine introduces an element that inherently makes it, I think, somewhat more difficult to relax and go to sleep.
Yep. Any medications that you might give to someone that won't mess with their sleep apnea if they have a machine that could help them sleep or at least get to sleep?
I think melatonin has been shown to be safe. It does not have any direct respiratory suppressant properties, does not alter sensitivity to CO2. The benzodiazepines are at the other end of the spectrum. They're definitely a no. The Z drugs are not as dangerous, but they're also, as was noted, don't have much data to support efficacy. The low-dose antihistamine, like hydroxyzine, may help with going to sleep. I've not seen as much benefit in helping to keep the person asleep. But sometimes it is a problem of going to sleep while wearing a CPAP machine. So I have used hydroxyzine for that reason.
Okay.
The other element, although I've not seen great studies so far, is the orexin antagonists don't appear to have a direct respiratory suppressant effect either. So they may be safe, but they haven't been widely enough used, in part because they are still proprietary and therefore expensive.
Another big category of questions was with the treatment of bipolar, let's say acute treatment, they're in the hospital. What might you use to help them sleep? What would be like your first line, second line?
Usually first line for them is Zopiclone. And sometimes the approved dose range for Zopiclone is 1 to 3 milligrams. Frankly, for our acutely manic patients, that sometimes gets pushed up to as much as 8 milligrams because maintenance of sleep during acute mania is very important.
Whoa. 8 milligrams?
Yes.
Okay, that's new for me. Wow.
And it works. It works fairly well without much in the way of adverse effects. Now, they don't stay at that dose because, frankly, when they're not manic, they don't need that kind of dose to sleep, and they may not need anything at all. So this is during acute treatment of mania. And so far, we've been doing that for about the last decade in the state hospital, and it has worked well in those cases where the person is hypomanic or manic. Because, of course, the issue with insomnia in somebody who's bipolar is that sleep deprivation, especially in the latter half of the night, acts as an antidepressant and will actually drive the person's hypomania or mania.
I was gonna. I just asked. When I was looking through the literature on azopiclone, I was actually kind of surprised as to how very little side effects I could find that were consistent across the studies. Dry mouth, unpleasant taste were like the ones that kept popping up, but it doesn't really seem to impair next day performance as far as I could see.
No, it doesn't, and that tends to be true even at higher doses. In fact, in Europe, to give credit where credit is due, we did not invent the higher dose usage. That actually came out of France, which has had access to zopiclone and S-zopiclone for decades. And in circumstances where the insomnia is refractory, or in context of things like mania, they've used it at higher doses for a long, long time without much in the way of adverse effects.
What about the difference between S-zopiclone and Ambien zolpidem? Do you see a difference between specifically sleepwalking, sleep eating, activities where they're not remembering them?
Yes, zolpidem is much more prone to inducing dissociative episodes. In fact, when zolpidem was first marketed, one hotel chain in the UK took to instructing their staff to keep large bath towels at the front desk because they kept having naked guests wander down to the lobby in a disoriented state. And they would have to wrap them up and take them back to their room, basically. Now, to be fair, many of these people had inadvisedly decided to have a nightcap to wash down their zolpidem, thereby dramatically increasing the probability of a dissociative state.
Ooh, that brings up a really good point. Which of these medications, if you were to drink alcohol, would you not use?
Benzodiazepines and Z-drugs, because they are acting via GABAergic systems. The orexin antagonists and the chronobiological drugs don't seem to have much of a direct interaction with ethyl alcohol.
What about cannabis? If you had a patient who was unwilling to quit their cannabis, would any of these drugs interact with cannabis in a negative way?
There have been very small, usually anecdotal case reports. Zolpidem, again, in particular, combined with cannabis, seems to be, again, prone to cause a dissociative mental state. There are very good reasons why in the package insert for Zolpidem, it basically says, take the drug and go immediately to bed. Do not pass go, don't do anything else. Because if the person is doing anything else that alters the drug, like drinking alcohol or taking cannabis, it appears to be then dramatically more prone to causing dissociation.
Nice. Okay. So you talked about different phases of sleep. Let's say it's terminal insomnia. Is there a specific strategy? Let's say they have depression with terminal insomnia, which seems to be sometimes more the melancholic type of insomnia or melancholic type of depression. Is there any treatment for that specifically, or does that need to be treated in your mind?
Certainly the principal treatment is treatment of the depression itself. Giving the person melatonin or one of the melatonin analogs when they wake up too early may help them by tending to phase delay their clock. I tend to stay away from other sedatives in that context because most of the sedatives we give don't have half-lives that are long enough to be effective for terminal insomnia. And that's especially true in the Z drug. Zaloplan has a 1-hour half-life. Zolpidem has about a 2 to 3 hour half-life. As zopiclone comes the closest, having a 4 to 6 hour half-life, but even it is waning quite a bit by the time you get to the point where the person with terminal insomnia would benefit. And of course, if they take a dose when they wake up in the wee hours, they then are prone to having essentially hangover symptoms when they actually should then be awake.
So this doesn't apply to terminal insomnia, but I do, just because we're talking about azopiclone, want to bring up a study that was done in 2006 where they looked at, patients that met criteria for major depressive disorder and persistent insomnia, and they looked to see whether, fluoxetine, treating the depression with fluoxetine in the morning, and then these patients were randomized to either placebo or azopiclone at bedtime, and the duration was for about 8 weeks, and they actually found greater reduction in both depressive symptoms, which they identified through like the HAM-D and the CGI scores, a greater significant reduction in depressive symptoms in the group that took both azopiclone and fluoxetine, as well as greater reductions in sleep latency, wake after sleep onset, and greater increases in total sleep time.
Mm-hmm. Yeah. Azopiclone has been, again, the one drug in this context that has produced benefit. The other Z drugs, albeit I haven't seen a good study of zolpidem controlled release, which is really like taking 2 doses. Zolpidem, though, and Zaloplan in particular have half-lives that are too short to have much effect on terminal insomnia. Azopiclone is much closer to the mark.
Okay, so let's say you had a patient with dizziness. Now, there could be 3 different types of dizziness. Could be vertigo, could be orthostatic hypotension, or could be like dizziness. First of all, like, would any of these meds worsen dizziness during the day? And if you were to have a patient who was very dizzy, which meds would probably be the best bet?
Certainly, if the person had dizziness related to orthostasis, I would want to stay away from any drug that had alpha adrenergic antagonist properties, because that will do a wonderful job of making them more orthostatic. Vertigo is not typically adversely affected by most of the sedative drugs. What I've seen in some people is an exquisite sensitiveness to what amounts really to mild ataxia. And for them, almost all of the sedative drugs can cause worsening. So I would be looking for either use of a chronobiologic drug like melatonin, or with a sedative drug like a Z drug, I'd be choosing the ones with the shortest half-life, so that essentially the drug would be gone by the time they got up the next day.
And which of the Z drugs has the shortest half-life?
Zaloplan is the shortest with a 1-hour half-life. So it peaks at about 45 to 60 minutes after you swallow the pill. And then from there, 5 hours later, it's gone.
Okay, that's helpful. Okay, I think we are kind of nearing saturation probably for the audience for this session. And
are you suggesting we may have put them to sleep?
It's funny. I have a couple people who have emailed me that have told me that for some reason our episodes, Dr. Cummings, put them to sleep, and they like to listen to it on repeat. So
maybe instead of looking at a screen, they should listen to this episode before going to bed.
Yeah, well, I don't have any objection to helping people relax. So.
Yeah, I warn them about driving and listening to us if that's the case.
Yes. Do not operate heavy machinery until you know how these podcasts will affect you.
Yeah. Okay, so if you are the serious curious, go to our resource library, download this handout, go on the psychiatrypodcast.com. It's there. It's free. You've joined the mailing list by signing up for it. And Dr. Cummings, any final kind of thoughts, pearls of wisdom that you want to throw out there before we kind of bring this to a close?
I think the one thing I would repeat for the providers and psychiatrists is when somebody says, I can't sleep, ask more questions before choosing an intervention.
Yeah. And I think I would repeat, think about the things that are not broadcasted by drug companies that are going to make a lot of money from broadcasting it, or people coming to your office as well. Think about exercise, think about the lifestyle changes. Notice that we started with about a half an hour of that. And I think as prescribers and as psychiatrists, we want to help our clients. And so, not feeling guilty when we do prescribe medications if it's necessary, but thinking long-term, we're going to continue to work on some of these lifestyle factors that make a big difference. That would be one of my closing thoughts. Any closing thoughts, Dr. Tomatsu?
Yeah, I agree with everything you both have said. I definitely am a huge proponent of CBT-I. I wish that it wasn't so expensive for people and it was more affordable. But one thing that I do like to keep in mind when I do see patients with insomnia is that not everybody is the same. And so kind of going back to that, story with the patient who would watch that cowboy TV, in general, TV is not good to watch before bedtime, but in her particular case, this was something that was soothing. But like Dr. Cummings said, then you would have to put a timer on the TV and sort of modify therapy according to who the patient is.
Good. Excellent thought.
Excellent thought. Any final thoughts, Dr. Krishnan?
I would just, exactly like Dr. Tomatsu and Dr. Cummings had said, it's always really important to, personalize the care to each patient. And, always just kind of look at the big picture, like never forget that in terms of, what are the other causes that may be contributing to the insomnia.
Yeah, and Dr. Krishnan is an interest in trauma, and I've had a lot of clients who have had something traumatic happen and then the insomnia started afterwards. And so sometimes it's about doing the deeper work and going back to when this started and what led to this start.
Exactly. I am like a huge, I have this belief that, trauma really underlies like pretty much everything,
Yeah, well, it's been a pleasure. I'm really glad to put this stuff out there for free for people. And if you want CME, of course, you can sign up for the CME. That helps fund the staff to develop the audio. And we will leave it there for today.
Okay. Thank you.
Thank you.
Thank you.
All right, guys, take care. I just want to give a special thanks to Dr. Tomatsu and Dr. Krishnan. They did an amazing job preparing for this episode. And also, I'm very thankful for my continued mentorship with Dr. Cummings. What a resource, huh? I get emails thanking Dr. Cummings, and I forward them to him. And so if you have any thoughtful words that you want me to pass on, I would love to. I'm going to have him on for a future episode, actually, on a book that he released on psychotic disorders, treatment-resistant psychotic disorders. So if you want to pre-read that book with me, that would be awesome. I am looking forward to that. Once again, if you want to sign up for CME, just go to psychiatrypodcast.com. It's super easy and straightforward to sign up. And it does help move things along in terms of getting episodes out, blocking off time to mentor and to guide the formation of these episodes. So I will leave it there for today. Have a great day.